Hello, friends. Welcome back to my YouTube channel, Pathology Academy. I'm Dr. Aditi Kumar, and today I will be talking about choriocarcinoma. Choriocarcinoma is an aggressive form of gestational trophoblastic neoplasia composed of syncytial trophoblast, cytotrophoblast, and intermediate trophoblast. It most commonly arises from the uterus. Etiology is that it arises from trophoblastic cells of previous pregnancy, most commonly after complete hereditary form mole. It can also arise less commonly after non-molar miscarriages and ectopic pregnancies. Intraplacental choriocarcinoma can occur after non-molar pregnancies, usually in the third trimester or postpartum. Talking about the clinical features, vaginal bleeding is the most common clinical symptom. It can also present with as metastatic disease, especially after non-molar pregnancies. If in lungs, then patient will present with dyspnea and hemoptysis. In the lower genital tract, patient will present with volute nodules located in the vulva, vagina, or cervix. If in the liver, then there is abnormal liver function test, intra-abdominal hemorrhage, and if it is metastasized to brain, then it will present with neurological symptoms like convulsions, altered mental status, etc. Elevated HCG levels and imaging is usually done for detection of choriocarcinoma. Histopathology is rarely required. HCG is a reliable marker of the disease as it reflects the tumor burden. Therefore, it is used for diagnosis, follow up, evaluation of therapy response, and screening of recurrences. On pelvic ultrasound, choriocarcinoma appear as a heterogeneous hypoechoic or hyperechoic mass with increased vascularization on Doppler. So it's highly vascular periphery with avascular central portion can be seen in this image. Grossly, these tumors are dark red, solid, tribal tumor with areas of hemorrhage and necrosis. Intraplacental choriocarcinoma can be subtle lesion grossly and commonly mistaken for placental infarct. The most common location for these tumors is endomyometrin. On microscopy, solid sheets of atypical syncytial trophoblast, cytotrophoblast, and intermediate trophoblast is seen. Note that there is always absence of chorionic villi except in intraplacental choriocarcinoma where the tumor is surrounded by villi. The tumor has infiltrative and destructive pattern. It has high mitotic count and the background can show necrosis and hemorrhage. IHC stains show reactivity for HCG, which is diffuse, P63, which is focal, and HPL, which is focal. Here in this micrograph, from a case of choriocarcinoma, you can appreciate the three population of trophoblast, cytotrophoblast, syncytiotrophoblastic, and intermediate trophoblast. And also with the arrow, I have denoted a mitotic figure. So there is increased number of mitotic figures in choriocarcinoma. Coming to the differential diagnosis, two main differential diagnoses are placental site trophoblastic tumor and epithelioid trophoblastic tumor. Well, in placental site trophoblastic tumor, it is composed of implantation type intermediate trophoblasts. So there will be only a single population of mononuclear cells with eosinophilic and amphiphilic cytoplasm, and it diffusely reacts for HPL and MELCAM and focal positivity for HCG. Epithelioid trophoblastic tumor is composed of chorionic type intermediate trophoblast and is characterized by a single population of mononuclear cells with eosinophilic to clear cytoplasm. And in contrast, where the choriocarcinoma is comprised of three types of cells, and there is diffuse positivity for P63 in epithelioid trophoblastic tumor, focal positivity for HCG and MELCAM and HPL. The treatment of choriocarcinoma is chemotherapy, which is methotrexate based. Surgery is only performed in selected cases like older age, chemo resistance, uterine rupture by tumor, or life threatening hemorrhage. So, this was all about choriocarcinoma today. Thank you for watching, and do like and subscribe to my channel if you're liking these videos.